Greetings, everybody. Thanks for joining us in this educational webinar. Allow me to thank and welcome Dr. Suhaila, our speaker of the night. Dr. Suhaila is a neurologist and an epileptologist who completed her neurology training and board certification in Saudi Arabia, followed by getting the Australian Neurology Board certification. She completed then clinical fellowship in epilepsy in Australia and got further subspecialized in through a fellowship in neuromodulation. She's currently working as a consultant neurologist at King Fahd Specialist Hospital, where she also served as the director of the adult neurology residency program. She has special interest in neuromodulation, epilepsy, and women's health and epilepsy. Dr. Suhaila is going to educate us about immunotherapy in NORSE with negative autoimmune workup. I encourage everybody to type their questions in the chat, and we'll try to answer your question at the end of this webinar. Go ahead, Dr. Suhaila. The floor is yours.
Thank you very much, Dr. Muntaha, for the introduction, and thank you for the opportunity to join you today to discuss the immunotherapy in NORSE fires with a negative autoimmune workup. I have nothing to disclose. These are my objectives. First, I will define NORSE, the new onset refractory status epilepticus, and fires. Next, I will review the pathophysiology, focusing on the role of cytokine biomarkers and how they may guide the treatment selection. Finally, I will review the current evidence for immunotherapy in patients with NORSE fires and negative immune workup. So first, let's go over the definitions. NORSE is a clinical presentation. It's not a specific diagnosis. It's an umbrella term of different diagnoses, also excluding other diagnoses. In a patient without, NORSE is diagnosed in a patient without active epilepsy or other pre-existing relevant neurological disorders, with new onset of refractory status epilepticus without a clear acute or active structural, toxic, or metabolic cause. Fires is a subcategory of NORSE that requires a prior febrile infection with fever starting between 2 weeks and 24 hours prior to the onset of refractory status epilepticus, with or without fever at onset of status epilepticus. Regarding the cryptogenic subgroup, cryptogenic NORSE or fires, this term applies to patients with the clinical presentation of NORSE, but in whom the cause remains unknown after extensive workup, as autoimmune workup and other workups, which may take several weeks to complete. Next, please. Okay, so if we look into the etiology of fires and NORSE, you can see that the cryptogenic accounts for the largest proportion of the cases, making it the most common etiology. On the left side is a cohort of adult patients, and you can see here that cryptogenic actually accounts for 52% of all the etiology. And on the right side, in the pediatrics group, you can see that the cryptogenic accounts for 58% of the etiology or the cases. Next. So understanding NORSE or cryptogenic NORSE pathophysiology and the mechanisms during refractory status epilepticus can guide the choice of a specific immunotherapy. So let's simplify the immune system. So the immune system composed of two closely interconnected systems. On the left side is the innate immunity, and on the right side is the adaptive immunity. And there is a crucial role of cytokines in mediating the communication between those two immune systems. So in case of any brain insult, the innate immunity is the first line defense. They are driven by the glial cells in the CNS, along with the phagocytes, dendritic cells, the NK cells, mast cells, eosinophils, and basophils in the peripheral nervous system. And then that will lead to the production of pro-inflammatory cytokines. While the adaptive immunity on the right side is an antigen specific, which eliminates the infection. So the influx of the immune cells, T cells, B cells, will lead to formation of antibodies. Both of these systems will lead to a neural excitability and can affect the blood-brain barrier integrity, potentially leading to seizure. Next. Next. Yeah. As I mentioned, that cytokines mediate the communication between the two systems. And in this slide, I group the cytokines in two ways. The first is functionally, whereas the pro-inflammatory cytokines, which promotes the immune recruitment and activation, such as the interleukin 1 beta, interleukin 6, tumor necrosis factor alpha, and interferon gamma. Or the anti-inflammatory cytokines, which limit the excessive immune response, for example, the interleukin 10 or the tumor or the TGF beta. And also we can divide the or group the cytokines based on their structures. Which can fall into a few families. The interleukin, the chemokines as CXCL or CCL, for example, the CXCL8, which direct neutrophil migration, and the CCL2 direct the monocyte migration. And also we can also categorize it into TNF, which is the tumor necrosis factor, the IFN, interferon, or the TGF beta, which is the transforming growth factor beta. Next slide. So from the cytokines to gene expression, there is two key pathways. The first pathway is the granulocyte colony stimulating factors, in which the monocytes or macrophages produce the GCSF, which binds on its own receptors on the bone marrow stem cells, which signal the transduction drives differentiation into neutrophils. And then it follow the CXCL8 to the side of the inflammation. The neutrophils will follow. And the second pathway is the JAK-STAT. And the key link here is how the cytokines binding at the receptor gets converted into the gene expression and turning a local innate signal into an adaptive T-cell driven response. The next slide. So over the past few years, several studies have indicated that the pathophysiology of cryptogenic NORSE differs from that of non-cryptogenic NORSE. On the left side, the study by Wang and his group, they compared the two major causes of NORSE, the anti-NMDA or encephalitis NORSE and the cryptogenic NORSE. And they found out that CSF protein profile differed, which suggests that the cryptogenic NORSE is more strongly associated with activation of the innate immune system than the adaptive immune system. And on the right side is another study by Henin and her group, where the NORSE cases or patients, 83% of them, they were cryptogenic NORSE, and they compared the CSF and serum cytokines, chemokines profile against the control group, which could be normal patient or refractory status epilepsy patient. And they found significantly elevated innate immunity markers in both the CSF and serum in cryptogenic NORSE. In the next page and the next slide, you will see the most comprehensive study in clustering the NORSE patient by a cytokine panel and clinical features. So in this study, they compare 62 NORSE patients with 45 patients with refractory status epilepticus with a known etiology, and 18 patients who are control, who have neuropathy or normal, but they don't have epilepsy. And they saw that in cryptogenic NORSE, there is an elevated pro-inflammatory innate immunity related cytokines versus both the comparison group. And using those broad cytokines, chemokines panel, they identified three major clusters based on the clinical profile and the biomarkers. So you can see here is in the y-axis, they mentioned the inflammatory profile and which pathway is involved, the median age, fires, CSF profile, and the outcome at the last follow-up. Also, they mentioned the post-NORSE epilepsy, which is defined as one provoked seizure after the initial hospitalization for NORSE. And then they suggested targeted immunotherapy, and this suggestion is just preliminary, not based on patient response. So we can see here in cluster A that there is no inflammation and there is no overexpression of any pathway. The patients in this group were old in comparison with the other groups, and 46% of them had fires. The CSF was normal. They had a poor outcome, and 38 of them, they had post-NORSE epilepsy, and there was no immunotherapy suggestion from the paper. And if we see the cluster B patient, they had innate immunity, cytokine-driven inflammatory response. There was overexpressed pathways of the leukocyte migration, degranulation, and the HLH pathway. And we can see here that those patients had pleocytosis. They were younger in comparison with the cluster A. They had a very poor prognosis. They had the higher incidence of post-NORSE epilepsy, and the suggested targeted immunotherapy is anakinra, tocilizumab, anti-CXCL8, and also anti-JAK receptor. When we go to the cluster C, we can see also that there was dysregulated autoimmunity process. The overexpression of the pathway was in the JAK stat, the T cell function, and the autoimmunity. In cluster C, the patients were the youngest. They had good prognosis. They had also less post-NORSE epilepsy in comparison with the cluster B. And because it's like there isn't antibodies, so we will use a targeted medication as rituximab, cyclophosphamide. And we can use also the JAK inhibitors. So we'll go to the next slide. And in this slide, actually, we wanted to see if there is differences in the cytokine profile between patients with fires and afebrile NORSE. And this study summarized the finding in 29 studies that reported CSF and serum cytokines level in NORSE and fires, and they are actually focused on the cryptogenic cases. And there was no significant differences in the cytokine profile between fires and afebrile NORSE. Next slide. Regarding the management, there is no evidence for favor certain types of immunological intervention in cryptogenic NORSE. I will just go over this consensus-based recommendation, which was published in 2022. And they intended to serve, and this paper intended to serve as a recommendations rather than strict guidelines. So in the next page, next page, please. So yeah, so here we can see the treatment algorithm for NORSE and fires. So can you click, please? And the first we have to stabilize the patient with initial treatment of status epilepticus, and there is no recommendation for what anti-seizure medication to use. Just we can use as per published recommendation or local guidelines to treat status epilepticus or refractory status epilepticus. And during this time, we will be waiting for the diagnostic workup. So the expert recommended can you click it, please? So the expert recommended that initiating the first immunotherapy once the initial etiology workup is completed, which is usually within 72 hours, and then to initiate it with the first line therapy, which is the immune therapy, either with IV methylprednisolone, which is 20 to 30 milligram per kg per day for 3 to 5 days, or with IVIG with a dose of 2 gram per kg over to 2 to 5 days. We can use plasma exchange in certain condition when we know that antibodies. If there is, and usually, and given the response to the first line treatment is often incomplete, the consensus among the expert is to initiate the second line. And before initiating the second line, all the children and adults, if it's available, we should initiate ketogenic diet, and this should be within 1 week since the onset of status epilepticus. If the oral is not available, parenteral administration is recommended. Also within 7 days, we have to initiate the second line immunotherapy within 1 week. If the antibody is mediated, so we will use the rituximab, and in our case, if it's cryptogenic, so we will use the interleukin R antagonist, which is the anakinra, or interleukin 6 antagonist, which is the tocilizumab. Unfortunately, can we go to the other slide, please? Unfortunately, the consensus group did not omit dose, frequency, or duration for the second line therapy because the evidence base is limited to case report and small case series, so it's not controlled trial. So in this systematic review of a publication from Henin and her group of publications from 2016 to 2023 in patients with NORSE and primarily cryptogenic, more than 83% of them were cryptogenic NORSE or fires. They used the anakinra, tocilizumab, and intrathecal dexamethasone, and they compare those three medication, and the analysis revealed significant heterogeneity in the treatment regimen, including the number and the type of immunotherapy used, their combination and variation in timing, duration, and dosing administration. So in the next slide, I will show you like an outline or a summary of the three medications. So you can see here that in anakinra, which is a recombinant interleukin-1 receptor antagonist, it was predominantly used in children with fires. It was used as subcutaneous or IV, and it was found that the half-life is 4 to 6 hours. Anakinra has a good blood-brain barrier penetration. The studies varied with the dose that was used from 2 to 20 milligram per kg per day. The maximum dose was less or equal to 400 milligram per day. However, the author recommended dose was 10 milligram per kg per day. There is no duration guidance, and it was effective in 73% of the patients, but by it decreases the seizure frequency, and that was assessed either by clinical or by the EEG epileptiform improvement. The side effect was reported in 48% of the cases, with the most common one is the side effect from the site of the injection. Also, infection 35%, cytopenia in 10%, and DRESS in 10%. And tocilizumab, it was used, which is a recombinant humanized monoclonal antibody targeting the interleukin-6 receptor. It was used it was used predominantly in adults. 70% of them, they had fires. The half-life was 6 to 18 days. It has poor blood-brain barrier penetration. However, due to the status epilepticus, there will be disruption in the blood-brain barrier, so that will improve its penetration. The doses that is reported in the study was 4 to 12 milligram per kg per dose, and it was given in an interval between 1 to 4 weeks. However, the author recommend 8 to 12 milligram per kg per dose every 2 to 4 weeks. There was no guideline established for the duration. It worked in 70% of the patients by decreasing the seizures. Actually, the side effects was reported more frequently than anakinra, and 50% of the patients, they had infection, and 38% they had cytopenia. Intrathecal dexamethasone actually was used also in 8 patients, all of them children, all of them with fires. And it was only used when is anakinra not available, also the tocilizumab unavailable. It was given intrathecally, half-life 8 hours, and it's bypassed the blood-brain barrier. The reported dose was between 0.15 to 0.25 milligram per kg. It was given 4 to 8 doses in interval of 1 to 6 days. The author did not recommend any dose, and there was no guidelines established regarding the duration. They noticed that 50% of the patient, they had improved, their seizure were improved, and they were weaned off sedation 5 days after the initiation. There was also no side effects reported. So the next slide, we will see the key conclusions. The key conclusion of this study that anakinra was mainly chosen for elevated interleukin-6, interleukin-1 beta, or CXCL8, interleukin-8. And they noticed that after the treatment, those cytokines they often falls. Tocilizumab also was used in interleukin-6. It's normalized in some responders, but some of those responders relapsed later. And as I mentioned, the intrathecal dexamethasone was reserved when those medications are not available. What we concluded also from the study that there is no validated cytokine profile to predict the response or the outcome. And one of the important things that we saw in this study that response usually seen within 1 week. So the 2-week mark is reasonable to assess and consider to switch to another medication in case of there is no improvement. Also, we noted they reported that the chronic phase of anakinra or tocilizumab, they saw that 67% of the patient had reduction in their seizure frequency, and I will discuss this later. Neither the drug showed a consistent effect on post-NORSE epilepsy or long-term outcome when they started during the acute phase. Can we go to the next slide? So important to note here that the timing may still matter for the acute phase. This separate study of 27 patients treated with anakinra and or tocilizumab from 2016 to 2023, they noticed that early administration of those medication associated with shorter duration of status epilepticus and lower frequency of a brain atrophy. However, the long-term outcome impact is still uncertain. Next slide. So let's talk a bit more about the intrathecal dexamethasone. It's not a new medication. It's already established or used in other conditions as a chemotherapy for leukemia, HLH, autoimmune CNS, lupus, refractory autoimmune encephalitis. And the initial report in NORSE was in 2021. On the left side, you can, in the left side, in this study by Muller and his colleagues, this study was multi-center case series where they reported 2 patients with cryptogenic NORSE and fired patients. 10 of them were children, 2 adults. They actually reported benefit in 10 out of the 12 patients, which is maybe promising. And on the right side, this is a study by Fisher and her colleagues. And they reported 2 cases in which both children had cryptogenic fires and they were unable to wean them off the anesthesia infusion. So the intrathecal dexamethasone was added on top of the systemic immunotherapy, and both of them were successfully weaned off the anesthesia. They noticed that, and after that, there was no seizure recurrence in the acute phase, and also there is no infection or adverse effects. Although these findings suggest a promising rule for intrathecal dexamethasone, but further studies are needed to confirm its safety and efficacy, and also to determine the long-term outcome. So, how long should we continue the treatment? On the next slide. Yes, how long should we continue the treatment? There is no dedicated evidence-based guidance. Evidence-based, the guidance is limited to case report and small case series, and there is no controlled trials. However, in the consensus, they recommended that if the keto diet was effective in the acute phase, it should be continued into the post-acute phase for at least 3 months. And for the immunotherapy, if it's effective in the acute phase, it also should be continued for at least 3 months. Also, for sure, we need to refer the patient for adequate rehabilitation for the motor and cognitive, also for screening for psychiatric conditions or sleep disorder. The next slide. So what will happen if there is recurrent or in case of chronic NORSE fires? Again, there is no evidence support the efficacy of any specific anti-seizure medication in the post-acute phase. However, anakinra and tocilizumab may have a therapeutic role even if not tried during the acute phase. Steroid pulse also has a role. We can use it, but we can't use it on a daily, as a maintenance. VNS may be effective. DPS, no evidence. And if the seizure reoccur during the treatment withdrawal, the previous immunomodulation should be resumed. So the next slide will show, in the next slide, this is actually again from Hannon's slide, the systematic review that I showed earlier. So here here they mentioned patient who 6 patients actually who started anakinra or tocilizumab as an outpatient months to years after the acute episode, NORSE episode has and when it's the acute episode has already resolved. And they mentioned that all the patients had a good response in which the seizures were reduced 20 to 50%. So the reduction rate was 20 to 50%, and there was no serious adverse event. The caveat here is that this is only 6 patients, in total across 2 reports. So this is suggestive and not definite that we can use about the effect of long-term use of this medication in the chronic phase. In the other slide, also, I'm going to talk about the vagal nerve stimulation. And the consensus, they said we can use VNS in the chronic phase, but not the acute phase. And there is very small and fragmented evidence, mainly pediatrics. And usually VNS is used in adjunctive therapy, is not like it's an add-on. There is actually all the cases that we saw is for pediatrics or adults in the acute phase, but only one case I have seen, which is in the chronic phase. Actually, it's the pediatric cases tends toward better, more consistent success than the adult acute cases. And in the chronic case, initially in the first 8 months, the patient was seizure freedom, had a seizure freedom, but then later the patient relapsed. Regarding the programming, it varies, and there was no standardization. And also the response, it varied from as fast as 3 days to as slow as 2 months. In the next slide, also DBS was tried in NORSE and FIRES in the acute and chronic phase. All this 4 published cases reported a favorable outcome. But this is very small case report level literature. Maybe there is a publication bias. But the interesting thing that they tried all the targets, the bilateral centromedian, the bilateral ANT, and the polyvinar. And the chronic case was in the ANT, and all of them, they were effective and seizure freedom. Okay, so there is also in the next slide, please. There is also other immunotherapies that been discussed for patients with cryptogenic NORSE in the recent years, including the JAK inhibitor and also the canakinumab. So JAK inhibitor, I already explained the pathophysiology before, and so it's actually there is 2 cases only. The animal data is promising, but the human evidence is just 2 case reports with mixed results. One had partial success with a safety issue. The patient had neutropenia, and one failure. There is no response to treatment. The other medication is the canakinumab. In the next slide, please. There is no published cases in NORSE, as I have seen, and it's only reported in one drug-resistant epilepsy patient who were started on anakinra and transitioned to canakinumab because of ineffectiveness. And it is a potential option when anakinra isn't available or importable. It has a poor brain barrier, blood-brain barrier penetration. But again, with the status epilepticus patient, the barrier will be disrupted. So my take-home messages are that, next slide, please. that cryptogenic NORSE is immunologically active, not immunologically silent, and it's driven predominantly by the innate immunity. There was no cytokines profile or biomarkers has yet been validated to reliably predict which drug will work or long-term outcome. The benefit of immunotherapy is clearest acutely in the earlier initiation is linked to the shorter status epilepticus duration and less brain atrophy. But there is no clear evidence that these therapies prevent post-NORSE epilepsy or improve the long-term functional outcome. So what is needed next is a standardized prospective head-to-head trial of second-line immunotherapy and biomarker-guided personalized treatment strategies. Thank you.
Thank you so much, Dr. Suhaila, for this really informative and well-organized talk. And thanks for the attendee for being with us. Please post your question in the chat if you have any. I can't see any as of now. So Hela, from your reading, do you have any preference, any preferred immunotherapy if you were to treat one of those patients and all of the options are available in your hands?
Actually, I don't have a preferred one. What I prefer is that to do cytokines testing so what I usually recommend, based on my literature review, what I would recommend is that if it's available, though it's not available in all the hospital, is to send for the cytokines profile in serum and CSF, and then to start one of the immunotherapy. And then per the systematic review by Henan, she mentioned that it's reasonable to assess and consider switching the medication in case of ineffectiveness. So we can start on one medication, and then when we get the cytokine profile and results, and then we can choose we can do the drug selection based on the cytokines. That's what I would do.
Suhaila, we have one question here. How much effective might methylprednisolone alone in NORSE and fires? And what's the percentage of patients that in which we need actually to go to escalate and use second-line immunotherapy?
Okay. Actually, I don't know about the percentage, and I haven't read something. I didn't cross in my reading. I didn't cross through my readings about any percentage. However, the response to the first-line treatment is often incomplete. That mean that most likely they will not benefit from the first-line treatment, and you need to escalate to the second-line treatment.
Then the second question is there any role for plasmapheresis in NORSE?
Sorry, is there any role of what?
Plasmapheresis in NORSE.
Plasmapheresis, usually you will use it with autoimmune mediated, with the antibodies mediated, I mean, more than cryptogenic. However, you can use it in certain type of situation, but the recommendation mainly is to use the methylprednisolone and IVIG.
We have another question here. Is there any role for immunotherapy or cytokine blockade agents in a super-refractory status epilepticus outside NORSE or FIRE? We mean here in a patient with a pre-existing epilepsy.
The what? Sorry, can you repeat again?
In a patient with a pre-existing epilepsy who's presenting with super-refractory status epilepticus, is there any role for immunotherapy or cytokine blockade agents?
Yes, because even because actually with the cytokine profiling, they compare the cytokine profiling. I mean, in the whole patient that, sorry, in the patients that they collected, I think 45 of them were patients with refractory status epilepticus, and with a good number of them, they had epilepsy. Epilepsy prior to the diagnosed prior to the presentation, or epilepsy diagnosed in the presentation because they were diagnosed with a genetic mutation. And they saw that the cytokines there was hypercytokinemia. So there is a rule actually of using the immunotherapy in refractory or supra-refractory status epilepticus, yes.
And then here there's another question, how to differentiate between post-NORSE epilepsy and chronic NORSE, and how to manage each one of them.
How to differentiate acute from?
No, yeah, but the post-NORSE epilepsy, like
Yes.
as a sequel of NORSE, versus chronic NORSE, like the persistence of NORSE, no, beyond the acute phase to a chronic phase.
Okay, so so post NORSE is defined when you will have one provoked seizure after the initial management as inpatient. So this is the post-NORSE. Chronic NORSE is when you have, and this is usually at the start of the treatment, at the start, I mean, of the disease. It could be actually immediately after discharge from the hospital. Chronic NORSE, I'm not sure actually. It could be, it's the same. I have no idea. Dr. Muntaha, do you have any comment about that?
No, as you mentioned.
Yeah, I think it's all the same actually, because it's post post-NORSE epilepsy is when you have one provoked seizure after the initial hospitalization. So once he's discharged, not on any immune medication. So this is the post-NORSE. Chronic, I'm not sure. I think they are the same. I didn't see any differentiation in any of those papers, so I'm not sure. But I don't think there is differences. And regarding the treatment, the acutely, I already mentioned the treatment, and the chronic phase also. If the patient was he was on the immunotherapy in the acute phase and he was responding to it, so we need to resume the same immune therapy. And even if in case the patient wasn't in immune therapy and the patient was on only the first line therapy, so even though that when the patient presents with a recurring epilepsy or seizures, then we have to start him in immunotherapy in the for like to treat him.
Here, one question about ketogenic diet and anakinra or tocilizumab. Do we need to introduce them simultaneously?
So what is recommended that anakinra is started within 7 days, and it can be at the same time simultaneously with the immunotherapy, the second line immunotherapy.
Another question about the role of surgery in NORSE, epilepsy surgery.
The epilepsy surgery. So what is recommended if there is a lesion? Then you can take a biopsy of it. So this is from the consensus. You can take a biopsy, but there is no a lot, no, nothing mentioned a lot about the surgery in the literature.
Mm.
But it is recommended, actually. Sorry, it is recommended if the patient had epilepsy to go through the epilepsy surgery if there is a lesion.
And then another question, do we need to check the serum IL-6 pre and post tocilizumab?
The serum, what? Cytokine?
Yeah, it's serum IL-6,
Yes.
the interleukin level pre and post medication. Do we
Yeah.
need to check it?
It's not about we need to check it or not. W- it's good to check the cytokines so you can do a treatment stratification and drug selection. And then afterward, it's nice also to check the cytokine level so you can monitor the patient and also for prognosis. Yes.
What else? Can we start here? One question. Can we start immunotherapy early before anesthetic drugs?
Immunotherapy before anesthetic drugs.
Right.
I don't think I crossed. No, I actually I saw some cases in the literature where they start the first line, not the second line, and I'm not sure if there is some of the cases that I missed. So I'm not sure actually. But logically, if you like if there is no response to the first line, you can go to the second line. For example, if the patient had focal seizures, focal aware seizure, like status, like status focal aware seizure or motor seizure. So then you don't need to use the anesthesia, right? So you can use the second line, yes.
Here is a question about is there any profile of abnormalities on MRI on NORSE or fire cases?
There is, sorry?
Any profile of abnormalities on MRI of NORSE and fire cases?
Yeah, so it was found actually when that usually you can see a hyperintensity signal and it is symmetrical. Um, that's it, yeah. And it can be anywhere. Mm. But when they compare it with the anti-NMDA, some of the especially the cryptogenic NORSE, they can present with MRI finding as the autoimmune encephalitis.
This question, I think you answered it already during the presentation. How many days immunotherapy we need to continue the patient?
Yeah,
Uh,
3 months. 3 months before you're trying to wean.
There's a question here that could you suggest an algorithm for proceeding in such cases? Should we repeat methyloprid, an IVIG, or go to intrathecal DEXA?
Repeat IVIG or
Yeah,
use the intrathecal dexta.
yeah.
Okay, so first, time is brain. So if IVIG did not work, you can go to the second line. And you can use IV, you can use intrathecal Dexa, but we have more cases, we have more literatures about the second line therapy as anakinra and tocilizumab. I'm not sure why you want to use specifically the intrathecal Dexa, but if the anakinra is not available or the tocilizumab, so yes, definitely after using the IVIG or the methylprednisolone and they did not work, go to the intrathecal Dexa.
Thank you so much, Suhaila, and thanks for everybody for attending tonight's webinar.
Thank you very much.